Well, Nunkari Nungi, everyone. Welcome to the race grand round, the last of our grand rounds for this year. And it's on a topic that's very important to us here in Riverland, Mallee Coorong. I'm on Errawong country today, and whether I'm on Errawong, Narkat, or Ngarrindjeri country in our region, the care of senior Australians is of paramount importance for our local health network. And we are very fortunate that it's not only a priority for us, but it's also a research priority for our state. And in fact, we, in many ways, lead the country in providing evidence-based opinion, evidence-based solutions for better care for senior Australians. We're privileged to have today Professor Maria Inacio, who is not only a distinguished professor at Flinders University and leads the ROSA group at SAMRI, but also has worked in really some of the premier relevant institutions in the world when it comes to evidence and care. Having worked at Dartmouth, which in many ways was the original area that value-based care was named and developed. So that experience, and then having worked with Kaiser Permanente, the largest HMO in the United States, and one that in many ways we're in a small way imitating. Kaiser started its own medical school, recognised that it needed to train its own workforce to be able to put in place the best possible care. And of course, we're looking at doing those same things by taking responsibility for training our workforce so that we can provide better care. So, Maria, welcome. Welcome to Errawong, Ngarrindjeri country. Knowledge that you're on Kaurna country today, and we're really looking forward to hearing about this unique database and the research that's brought it about and now is benefiting from it. Thank you.
Lovely. Thank you. And can you guys all hear me okay now and see my slides? Yeah?
Yes.
Fantastic. Thank you for that lovely introduction. It's quite a pleasure to be here and share a little bit of the work from the Registry of Senior Australians with all of you. I know that Stephanie Harrison from my team was here a couple months ago presenting an introduction of the work that we do and some of especially around the quality and safety monitoring that we do. So I decided to take a different approach and focus on some of the more exciting research that we are about to finalize and kind of give you an introduction and a taste for that, and also direct you to some information that you might be interested in receiving about LHN specific care and outcomes related to older people in both home care packages and residential care. Yeah, so I will just get started by just doing a brief introduction again for those of you that weren't at Stephanie's presentation on what the registry is and what the registry has, and then I'll move on into talking about this 4-year body of work that we've done around care integration for older people in home care and residential care. So the registry is based here at the South Australian Health and Medical Research Institute, and we recently established a partnership with Flinders University as an academic partner. We've grown from about one individual back in 2017 to about 30 plus now these days, all dedicated to working in research about older people and how we can improve the quality of the aging experiences that they have and also the services that they access. We have a lot of partners that are dedicated to the success of this work, and in a way that is what has made the registry's work be successful in being translated is the fact that we've worked with all these institutions from the beginning in establishing ROSA. So for those of you that are not familiar with what ROSA is, I think this picture is probably the one that best describes how we operate and what our framework is. And essentially what we do is we maintain 2 cohorts of people where we get essentially the permission for one of the cohorts in South Australia specifically to link all the information that are collected through their experiences with the aged care sector to all of their experiences in the healthcare sector. And then we maintain a national historical de-identified cohort of individuals where we link not only all of their aged care service records, but also their health records, their social welfare records, and a number of other smaller kind of boutique data sets that are available throughout Australia for very specific purposes, which then we bring together into the same working environment and derive new things and new information from it. So one of the main areas of focus of research that we have at ROSA is to leverage these existing data sets to allow us to monitor quality and safety in the experiences that people have in the aged care sector, and also to do research, for example, around better methods for doing this type of research, and then critical areas in the area of aged care. So care integration, for example, is probably one of the main areas that we work on. But we also do a lot of other things, like we develop profiling tools that individuals can use at different points of care, and we have one that has recently been introduced in SA Health. We've also do a lot of reports for providers, for the government, and put out a lot of educational material for the community to share, the findings of the work that we do. To date, the ROSA data has about 21 different data sources now within, and from 12 different custodians, and we use almost all of the data integrating authorities that are working on health data integration in Australia to help us make this happen. So it's quite the amazing feat in actually bringing these data sets together. So as I mentioned before, our core business really is doing quality and safety monitoring. That's why we were set up. And our reports for providers, I should say, the reports are available nationally, but we cannot identify providers on these reports. So we can just evaluate variation, we can evaluate patterns of care. But in South Australia, because we have this prospectively enrolled cohort of individuals that we've been consenting into the registry since 2018 through the ACAT teams, we are able to give information back to the providers themselves. So we've distributed now over 350 reports directly to South Australian providers around a set of metrics that we've developed using this existing data about how well the individuals within their care are faring. And I think that's what Stephanie has already introduced to you are these reports. The brief version of the report, not what the ones that the providers get themselves, are available online, and you can see it on our website. And this is just a screenshot of what the reports are. So for residential care, we report on 12 indicators, and for home care package recipients, we report on 15 different indicators. We also do provide that to the specific, since SA Health, for example, is an aged care provider, you can receive your own reports about the services that you run. So if you are involved in running any of those services and you want your report, please contact us and we're happy to share that with you. There is no cost. It's available for everybody. It does have to come from the CEO of the service though, or the lead of the service. But what we have decided to do as well to supplement the outcome monitoring system report on these indicators every year is to release a LHN specific report. So that way it can be distributed a bit more widely for people that are interested. And the one that I'm showing you here is the one that we released this year. The cohort was from 2021 to 2022, and essentially showed facilities within capture LHNs. So that way you know of the individuals that you're caring for, how the experiences that they're having within these 12 indicators that we're monitoring. And that's what this report has. Again, if you want this report, I can send it to you right after the meeting. And it outlines in here what, the Cullen facilities, the Nowlan facilities, the Salin facilities, and the regional facilities are doing in regards to each one of these metrics that we're monitoring. So that's my plug-in for all the quality and safety monitoring work that we do. I'll move on now to just sharing some of the findings from this 4-year body of work that we've had around access, variation, effectiveness, and costs of delivering primary care services and some certain subspecialty services to people both in residential care and in home care packages. I'm going to focus on just residential care today, just for the interest of time. And I'm just going to tell a little bit about the journey that we went in over these 4 years. And this is a medical research future fund funded project that we've done in partnership with a number of institutions as well as listed in here. So the first part of the work was around access. So our individuals in residential care facilities having a continuous access to the services that you would expect them to need, and what is the pattern of that, both before and after they enter care and over the years. And what we found, and I think this is probably comes as no surprise for most of you that are working in the sector, that there is definitely a suboptimal utilization of primary healthcare services and selected specialist services following entry to residential care, which is really discordant with what we know about the complex care needs of the individuals in residential care. So this figure right here is from one of the published studies that we have that describes the utilization of services. And this would be generic attendances. This would be health assessments and management plans. These are some of the specialty services that we looked at. These are the mental health services that we've looked at. And whether it changed after entry into permanent residential care. And you see some of them does change. We've also conducted all our analysis by whether individuals had dementia at entry into care or did not have dementia. And actually that didn't have a big influence actually on the relative views before and after. It did have a difference in the amounts of services, just a little bit that people get in some circumstances, in some scenarios. So what you can see here is that generally speaking, there might be an increase right after they go into care for some of the services, but not for most of them. And those increases are not sustained. But also, and I think this is an important point to make, is that there is an increase in after-hours attendances and urgent after-hours attendances, which are these figures right here after somebody goes into residential care, which is something that could be indicative of a poor care model within the facilities or access to, better, I guess, organized preventive care. The second part of what we've done then was looked at the variation of these services, because of course a lot of the people ask, well, is this true for rural facilities? Is this true for big facilities? What is the pattern of utilization in different places? And we've examined then for all of the services that we had looked, whether there was a difference by the size of the facilities, by the remoteness, by the ownership status. And we found that there were substantial differences on a number of services that were not explained by those by that. So after hours attendances, urgent after hours attendances, health assessments, management plans for dietary access, optometric services, and continuity of care, which is actually not just necessarily a service, but it's like the ability of continuing to see your own or somebody that you knew or your usual GP after moving into residential care, varied quite dramatically, no matter how you cut it. And this is the variation for specifically for continuity of care. And I'm picking on continuity of care now because I want to tell you about the effectiveness of continuity of care as well, which is the next part of the analysis that we did. So when we looked at continuity of care and how it varied nationally, if you look at the very first figure, the first part of this figure here, you can see there is enormous variation, but generally speaking, it's pretty low. Only 13% of residents continue to see their usual GP after they move into residential care. And about 11%, if I remember correctly, continue to see a known GP. So over 70% of them will have a completely new GP assigned to them after moving into care. But there is variation. Remoteness was one thing that we see a difference. So in non-metropolitan regions, those facilities did have a higher proportion of individuals that continue to see their usual GP. And for the other ones, there was maybe a little bit less in the government facilities, a little bit more in the government facilities that also continue to see their normal GP. Now, when we looked at, when we finished this report, we also heard from some of the LHN leaders that they would like to see this information by the LHNs, similarly to what we had done for the OMS reporting. So we provided then with a report that also describes for the facilities within your catchment area, whether there was a greater or lower variation of all of these services. Now, this data is a little bit older, it's from 2019, so it might not be, completely contemporary for you. But if you are interested, we can also share that report with you, because it does give you an understanding of all of the 88 facilities that are in the regional areas in our state. This is what the continuity of care prevalence is. This is what the access to health service, health assessments was, what chronic disease management plan was, at least in the year immediately before the pandemic. And you can say here, when we're looking at the variation, we knew the rural facilities were the ones that had a higher prevalence of continuity of care. This, again, I'm keeping on a theme of continuity of care here. And that's what you see here as well, is that these facilities have a higher prevalence of that. When we look then, so this is all fine and good. You assume that primary care service access translates into better health and translate into better outcomes for people. But that's not necessarily always true, right? There could be services that are overutilized that might not actually offer better benefits. And that's part of my training at Dartmouth, is the fact that there is, variation that sometimes is supplier induced and not necessarily translate into better outcomes. And at times, because we know that there's such a variation, we also know that there's likely disagreement on what should and shouldn't be the actual access. So there's unwarranted variation that we're identifying here. So what we decided to do was actually get a full analysis of the effect that these services offer, the benefits that these services could offer to these residents, to once and for all answer this question of which of these services are actually offering some of these benefits, quantify that benefit, and provide that evidence so we can advocate for better support and better integration and better financial incentives for this care integration. So I'm going to focus on just two of the things that we looked at. I'll just say that what we did was look at over 330,000 residents in 2,900 facilities throughout Australia. And we looked at the effect that each service or amounts of service that people received over a certain period after entered care would have on specific outcomes, like a variety of different hospitalization outcomes, ED presentations, and then mortality. And what I'm going to show to you today is really the results of the two things that had the most effect on better outcomes for older people in residential care in regards to primary and specialist care service access. And that was proactive and planned preventive and disease management care patterns and high continuity of care after entering residential care. So this is just a kind of a figure that outlines all of the services that we looked and all of the outcomes that we looked here. So I think there's 11 outcomes, and I think there was 16 services that we looked at. And then they're ranked by the ones that offer the most benefit to the ones that offer the least benefit. So you can see our after hours attendances here is at the bottom. As I mentioned before, this is something that increases substantially after people enter care, and it could be indicative of problems that are happening to the individual or in the models of care in that facility. But the things that offer the most benefit for the individuals are not just specific services, but patterns of services that they receive. And I'll explain to you how we estimated these patterns of service in just a second. And then continuity of care. So focusing on the patterns of service utilization, what we know is that individuals are not using one service in isolation, and that one service is unlikely to be offering most of the benefits. And so what we tried to do was estimate how did people actually go about using these services. And what we found is that there is actually 3 patterns of service utilization within these residents after they move into care. And this is using the first 6 months of their 1 year of their service utilization after entering into care. The 3 patterns we named then as people that have a low utilization of services in general. So they don't use a lot of the long GP consults, they don't use management plans, they don't use health assessments, they use very little allied health services that are subsidized by the MBS, they don't see a specialist, they don't have a whole lot of after hours. Overall, they just have very low utilization of services in general. Then there is this blue pattern of people that have what we are calling exemplary use. They have more preventive management, like more management plans, more health assessments, more allied health, low after-hours services, and low urgent after-hours services. And then conversely, there is actually a high utilization group that pretty much uses a lot of everything, and which was a bit surprising to me, actually. And interesting enough, they fall in just about one third, and one third of the cohort into these different patterns of utilization. Now, when we compare the patterns of utilization to the outcomes that these people experience, I think this is the really drastic differences between them. We see that this pattern of preventive health service utilization, when compared to people that just have very high utilization of everything, had a 11 to 37% lower risk of most of the outcomes that we examined. So you can see here, like the lower risk of this, each one of these specific outcomes. So lower risk, 20% lower risk of ED presentations, unplanned hospitalizations, potentially preventable hospitalizations, which is really striking. And again, when you compare it just to the people that had the preventive pattern of service utilization to just low utilization, so no utilization at all, similarly, you're seeing this 6 to 18% lower risk of hospitalization. So a little bit less, but lower. Now, when we've looked at continuity of care, which is the other thing that we were really interested in, we found that about 17% of people continue to see their usual GP in this cohort. So the information I shared with you before about prevalence was about 2019 specifically. This one is over a longer period of time. 11% saw their known GP after moving into care, and 71% only saw a brand new person. But even then, we see that continuing to see a usual GP was associated with a lower risk of most of the outcomes that we looked at, not most, but quite a few of the outcomes that we looked at, I think 5 of them. To me, the most striking difference here is really the benefits that it offers in relationship to the delirium and dementia-related hospitalizations for people that have dementia already. There's a 20% lower risk of them being hospitalized for these conditions. And I don't think I have a slide here on that, but it's similar even if they continue to see just a usual GP, a known GP. So as somebody they have seen in the past, that might not necessarily be their usual GP. So familiarity and that continuity of care means a lot for these residents. So I'll just wrap it up by saying that I think the work that we've done here has really shown that once people enter residential care, their healthcare continues to be a massive part of of the care that they need. It's not just about giving them a place to live. They need healthcare while they're there, and it affects their experiences, affects their mortality, affects their hospitalizations, and that invariably has to translate into better experiences while they're there. I also think that this is just more evidence that these sectors are intrinsically linked and you can't keep separating one from the other, and that this integration needs to be more financial structure and also of shared governance. And I think people always ask me what the recommendations are in regards to the findings that we make, and obviously this is a big stretch for me, but I think that it's obvious that better financial incentives need to be made, both for the aged care sector and the primary care sector, on how to make this happen. I know that workforce investments are, we talk about it all the time, and it's a real challenge, but it's another thing that obviously needs to be improved in order to be able to achieve this. And I didn't go into the allied health services or the services that are provided by non-GP providers here, but I think there is definitely a role for them to expand the role that they have in aged care based on some of the findings that we had. And the two last things that I'll just mention is that because these are important to the residents' health, I think that we should be monitoring this as well as part of some sort of quality improvement program. And I think we should also incentivize the integration of care through financial incentives. And also I'll just leave it here that don't forget that there is more people in home care packages which are having similar experiences that I didn't talk about today that are somewhat similar. And that's pretty much all I had for today. I'm just going to thank my team who makes all this happen that I mentioned before. There's quite a few of us these days, and everybody who provides us with support and funding to allow this work to happen.
Ananindi, thank you so much, Maria, for what is such a relevant presentation for us. Obviously, in our region, with a number of multi-purpose services and the integration of both home care, private general practice, aged care, and acute care, it's all part of our LHN's remit and commitment to our communities. So given your data, we should be seeing uh, you know, improved outcomes compared to the rest of the sector with that level of integration. You did show some of those initial sort of dot plots uh, right at the beginning. If you look at regional South Australia and you look at urban South Australia, do you see that improved those improvements in outcomes and in terms of decreased low value care and decreased hospitalisations? Do you see evidence of that at the moment, or is that further work that needs to occur because of the natural increase in continuity and the well, presumably increase in care planning, but I don't know if we do care planning better in rural areas or not. Continuity we do, but do we do it in care planning?
We consistently see the government-owned and rural community facilities doing better than the others in our data and our indicators. And there was also a nice Royal Commission report that we contribute information to, where they put our indicators as well as a lot of other indicators that they had collected from a number of other sources at the time. And I think it was something like 2/3 of them had better outcomes in smaller rural facilities compared to the others. So yes, and I can't shake the feeling based on what we've done now, seeing the integration and the better access to care, that it is that shared clinical governance that you guys have in these facilities and oversight and staff that you share and all that drives that. But really hard to prove that, but we consistently see that. So yes.
While other people might be thinking of questions, just to remind people that there is an email address there for both the ROSA team and Maria herself. But I can't help thinking that we often feel as though the accreditation process is sometimes starts with the assumption that it's going to be more difficult for us providing aged care because of scale issues of scale. What I'm hearing from you is that we actually have some advantages as well. Do you think the current accreditation process reflects those advantages or gives us the opportunity to show those advantages, or is it a bit stuck in process measures rather than outcome measures?
Yeah, that's a very good question. We haven't looked necessarily of the accreditation measures. My team is getting access to the complaints and serious incidents reports, which is yet another area of all this in the near future. And it will be our first foray of looking into it and comparing to the other things that we do. So I don't know. I can't really comment on that because I don't know. I don't know intimately what the process is. I see the outcomes, obviously, the published online, but not, I haven't worked with that data, so I'm not sure.
Yeah, it sounds to me as though that's a very fruitful area for research and something we would certainly be interested in collaborating with you on, because it's very important for us. The other area of linkage is that we are just in the process of putting together a dashboard for value-based care population health framework for our region. And clearly some of the indicators that you are developing as part of your work would be incredibly important on that value-based care framework. So some further discussions that we can have down the track. But I don't know about others on the grand round, but for me, this just raised so many questions that we have the opportunity to think about in terms of the way we structure our services. And as you said, this is just, you really only looked at, say, the contribution that general practice makes to residential aged care. Then there's the contribution of continuity in nursing, continuity in allied health, and access to allied health. There are all those other aspects that we can look at. Fabulous to know that this work is going on in South Australia for our whole country, and that potentially we can now benchmark ourselves in this way to best practice. So Maria, thank you so much, Ananinti. Thank you to everybody for your participation. This is our last grand round for this year, and it's, I think, been a real highlight presentation for us. So thanks for your participation. I hope the grand rounds are prompting ways that we can interact with the best in the world. And certainly ROSA is one of those leading lights for our state and our country. So thank you very much.